Good morning, and thank you for coming this morning. It is my great pleasure to introduce Dr. Sholl from Brigham and Women Hospital. So to tell you a few things about Dr. Sholl. So she graduated from Stanford University, and then she did her residency training in anatomic and clinical pathology at Brigham, and followed by 2 fellowships, one in thoracic pathology and the other one in molecular pathology. Then she stayed as a staff pathologist there, where she became associate pathologist. She is also associate professor of pathology at the Harvard Medical School. Currently, she's the director of thoracic pathology at Brigham as well, and the associate director of molecular diagnostics. So there are many things that I can tell you about Dr. Sholl. She published a lot of papers, more than 150 papers, and all of them are really important papers. But I want to tell you something that I learned over there, and then I will let Dr. Sholl to speak for herself. So the most important thing that I learned at Harvard and Brigham is that the strength of their team does not actually rely in the undeniable value of every member of their team over there, as much as it relies in the feeling that you get from being part of a family where the other members are not your mere colleagues, everyday work colleagues, but they're actually much more than that. They become your lifelong friends. So please welcome Dr. Sholl this morning. Thank you.
Thank you for the kind introduction. Very generously avoiding discussion of the abuses heaped upon him as a fellow in our thoracic division. But we do have fun. We have fun together. So it's really a pleasure to be here. I'm going to really focus very much on I'm going to put my molecular hat on, very much focus on the work that we're doing in the molecular space. This is an area that I think actually Emil has been able to take advantage of as well in his thoracic training. He actually had a platform presentation at USCAP 4 years ago or something on one of the topics I'm going to discuss today. So it's kind of a work in progress that has direct implications for, I think, surgical pathology, but something that we're still kind of building out in our molecular lab, and you'll see what I'm talking about as I get to that point. But of course, the other topic that I feel like we need to address in pathology is our role in selecting patients for immunotherapy, and I'm going to discuss that as sort of the first part of my talk. I do have a couple of disclosures, and then again, just to emphasize how we're going to break this down, we'll first talk a little bit about immunotherapy. I'm going to avoid talking about PD-L1. For those who have to sit with me at Sign Out Now, you were spared from this torture. But for those who have to sit with me at Sign Out Now, it's PD-L1 review is my least favorite activity, and I'm convinced it's a totally useless waste of time. So I'm not going to talk about that as a biomarker so much. I'll talk about some genomic approaches potentially that may or may not be any better than PD-L1, and then we'll talk a little bit more about just hypermutation in tumors, how we can actually exploit that from a diagnostic standpoint to really enhance our surgical pathology practice. So first, I wanted to set the stage by giving you a sense of the kind of genomics work that we've done at the Brigham and the Dana-Farber. And we're very fortunate at our institution to have benefited from some very visionary leadership back over 10 years ago, largely led by Barrett Rollins from the Dana-Farber and Nina Longtine, who was our former chief of our molecular division, who essentially said, we want to give all the patients who come to our institution an opportunity to get their tumors profiled one way or another. We're not going to define exactly how that profiling will take place, but we just want to create an infrastructure to enable that to happen. And so that's what this is. They launched what's called Profile. And essentially, it's just the nuts and bolts behind the scene of getting patients consented to testing, getting requests into our laboratory for testing, having a mechanism to actually perform a test in a CLIA laboratory that you can then act on, say for clinical trial enrollment or other purposes, deliver a palatable result back to the clinical team, and then also to put the data into a shared database that's accessible within the institution as well as publicly, so via submission of a lot of the data that we generate to the AACR Genie initiative. So this is something, again, that was sort of hatched about 10 years ago. It took us several years to kind of create the infrastructure. And then it's essentially been kind of a plug and play. We have this infrastructure in place, and as we develop a new approach to profiling a tumor, whether that be genomic or immunoprofiling or whatever we want to plug in there, we can just sort of put it in and reap the benefits of having an infrastructure in place to increase the number of patients that get tested and having a mechanism to report the results back. So this just gives you a sense of our timeline in a more concrete fashion. As I mentioned, it's kind of plug and play. So we started initially building this infrastructure out and plugging in initially a very simplified approach to tumor profiling, just a simple mass spec genotyping assay that was quite circumscribed, was actually not a very good test, looking back at it retrospectively, but it was a good way to kind of cut our teeth on the process. While we were working on that sort of very basic assay in the laboratory and working out the kinks of the process in terms of consenting patients and getting things reported out, we were validating our first version of our next-gen sequencing assay for cancer, largely focused on solid tumors, but also with some coverage for liquid tumors, lymphomas. And that was launched in August of 2013, and our first panel had 275 genes on it. We made a couple of updates to that panel the following year, bumped it up to about a 309 gene panel, made some changes to the chemistry, and we stuck with that for about 2 years, and then in about October of 2016, we launched the version of the panel that we use today. It's close to a 450 gene panel. It's a hybrid capture assay, which lets us do both mutation analysis as well as copy number alteration that's pretty reliable, as well as structural variant detection, so we can do some degree of fusion detection with this panel as well. And then following the launch of this latest version of the assay, we haven't done a whole lot to update the content of the panel that we're running, but we've changed chemistries, we've changed our bioinformatics pipelines. We've done a lot to enhance the interpretation side of this panel. So for instance, we rolled out mismatch repair and tumor mutational burden analysis for every case in 2017, and the date will become relevant in a couple of slides. And then we also rolled out mutational signatures, a broader way of looking at mutational changes in the tumor a couple months later. And then finally, most recently, rolled out immunoprofile, and I'll give you a sense of what that looks like for us later in the talk. And interspersed with this, we were trying to figure out ways to actually make this financially sustainable, because it's kind of not. So, I mean, if you have very, very rich benefactors, it works out fine. But those only stick around for so long, and so we needed to figure out a way to get billing to actually work from the clinical standpoint. So we started with thoracic oncology, which kind of made sense because they were the most mature in terms of NCCN guidelines and the number of genes you actually needed to test routinely in patients, especially with lung adenocarcinoma. So that we rolled out back in 2014, and we started doing some more clinical testing in 2017 for the other. Colon cancer is a big one for us now. Pancreatic cancer will be something we can roll out soon based on NCCN recommendations for BRCA testing, HR pathway testing in that particular tumor type, et cetera. So we kind of continue to build what we're billing out for. Just because we try to get paid for it clinically doesn't mean it actually happens. So it's one of the major challenges I think that we face as an institution, is figuring out how to make this longitudinally sustainable. So all of that behind us, I think one of the really wonderful things about having this type of infrastructure is that we've been able to really look at the data in a very broad and comprehensive fashion. We have a really talented bioinformatician named Ethan Cerami who runs what we call our knowledge systems group. They're situated at Dana-Farber, and they've built an internal instance of the CBio portal for our own data, which is great from the standpoint of a laboratory to be sort of running QC on the kind of patterns of mutational analysis that you're seeing in your tumors. It's great from a clinician standpoint, because if they want to, say, launch a clinical trial looking at inhibitors of BRAF codon 598, they can go into the CBio portal and say, how many cases of tumors have this particular mutation? Does it make sense to open a trial for this particular drug? And you can pull in some clinical data as well. This could be far more sophisticated than it actually is. A lot of the challenges that we face in terms of marrying a lot of the clinical and genomic data is actually annotating the clinical data in a way that you can kind of feed it into a data set like this and for it to be reliable. And then, of course, the other aspect of this is actually generating a report that's interpretable to the clinicians, and I'm not going to claim that this is interpretable. It's interpretable to some people, not to others. As these things go, these are 14-page reports. There's like no way around it by the time you get through all your disclaimers and your methodologies and your references, et cetera. And we don't even have pages and pages of theoretical clinical trial matches. You'll see some commercial laboratories that will give you 5 pages of clinical trial matches. We don't really go there. We don't necessarily feel like that's our role. What we do really emphasize is sort of taking a long list of variants and putting them in, at least putting them in a way that it's kind of prioritized. So this is the one that matters probably more than, say, this RECQL4 variant in this particular patient with a lung cancer. Identifying variants that may be interesting from a clinical trial or just purely biological standpoint, offering some kind of overall assessments, such as what the MMR status is, whether or not any other mutational signatures are analyzed, and just a couple of short comments about what the variants mean. We have a knowledge base that we've built over time within our group where essentially we have a variant, say, KRAS, mutation G12C, tumor type lung adenocarcinoma. All of that gets plugged into the knowledge base, and then we have automatic language that populates the report for that particular variant. So it saves us a lot of time, at least for hotspot mutations, in terms of interpreting the reports. One of the challenges of our assay is that it's a tumor-only assay, which means that we don't have a paired germline specimen, which means that we can't filter out germline polymorphisms using that paired specimen. We do a lot of computational filtering. We have lots of databases, Nomad, ESP, et cetera, that we will filter our results against to try to get rid of germline variants, but you just can't get rid of everybody's private germline variant. So that's a challenge that we always face, and that's one of the reasons that you see a whole bunch of mutations and things that we call tier 4. We don't really know if these are in the tumor, if they're in the patient's germline. One of the differences between us and I think some of the commercial laboratories is that we actually show you all of these things. So, and you could sort of say there's pros and cons to actually showing people those variants, but we tend to be of the sort of philosophy that if we have the data sitting in front of us, we'd rather share it with our audience. And again, it's more of really was born as a research initiative rather than a purely clinical initiative, so that's kind of the roots of our philosophy there. So anyway, that's what it looks like, our final product. The one thing I would say I don't show you here is our tumor mutational burden. We report that out at the top of every report, and you can argue whether that belongs at the top or in small print and as a footnote at the bottom of the report. But it goes to the top. I don't show it to you here. But the reason that we do this, of course, is because we're interested in figuring out ways to sort of leverage this data for identifying candidates for immunotherapy. And so I'll talk a bit about that. Some of this is sort of theoretical. Some of this is just sort of driving our own thinking internally. And of course, why are we thinking about this? So of course, the idea is that tumors have mutations in them. Mutations are different than the original code. They will generate proteins that are different than the original protein, so-called neoantigens. These neoantigens may or may not be presented at the surface of the tumor cell to the immune cells that may trigger kind of a recognition of foreignness and therefore drive the tumor cells to kind of recognize this is something that they should kill. Of course, this interaction has been associated with this adaptive immune response in lung cancers where this will actually trigger this interferon gamma environment, upregulating PD-L1, engaging the PD-L1, PD-1 axis, creating a milieu in which things like PD-1 inhibitors, PD-L1 inhibitors can be used to kind of block that interaction and allow the immune system to work to kill the tumor cells. So really, again, the whole sort of predicate here is that there's something about the tumor that's kind of triggering that interaction to happen. And a lot of what we're thinking about is what's happening at the very beginning here in the form of tumor mutations that are allowing those new antigens to form. And we know this is kind of a legitimate clinical variable because we've seen with things like mismatch repair deficiency, microsatellite unstable tumors that we have a very sort of striking biomarker of response for immunotherapy in patients who have this type of DNA defect in their tumors. And this is just the original clinical trial data from 2015 in colon cancer alone, and you can see that the survival curves very strongly are favoring mismatch repair deficient tumors over those that are proficient in patients who are getting pembrolizumab therapy. Of course, that expanded not just to that one PD-1 inhibitor, but to in colon cancer, but to a whole bunch of different tumor types. And this was all depending on whether they're mismatch repair deficient or not. So here we had a a tumor type agnostic biomarker that predicted response to this PD-1 inhibitor. And the thinking here is this mismatch repair deficiency is really very potent at generating neoantigens for a couple of reasons. Number one, these tumors tend to be very highly mutated. For anybody who's kind of looked at this mutational data will recognize that these are one of the more highly mutated tumors that we see in human biology. The types of mutations that mismatch repair deficiency actually creates are fairly unique in that it has a predilection to cause small insertion deletion mutations that lead to frame shifts in the coding sequence. And the frame shifts will generate these neopeptides. So instead of just a single missense mutation causing one codon to change, you'll see a whole stretch of neopeptide, which can be broken into maybe 2 or 3 neoantigens, which can then be presented to the cell on the cell surface. So instead of, say, 1 maybe weak neoantigen, maybe you have 3 very potent neoantigens from a single mutation. So it's sort of maybe an exponential increase in the number of actual neoantigens that can be generated. And of course, if this is an ongoing kind of deficiency in the tumor DNA repair mechanism, so it's not a single hit that happened 10 years ago that caused the DNA to get damaged. It's this ongoing issue, and so you're constantly going to see a refreshing of the neoantigens in these tumors. So it seems like this is a really very potent way to kind of drive immune recognition. So of course these observations led to this really breakthrough kind of unusual FDA approval of a PD-1 inhibitor, pembrolizumab, that was tumor type agnostic. This was our first tumor type agnostic approval by the FDA for any solid tumor that had mismatch repair deficiency. And you'll see this was in May of 2017. And we sort of saw the writing on the wall when this approval came through. Everybody and their brother would be emailing the pathology department. And I don't know what your experience was with this, but we had all sorts of people coming out of the woodwork and calling us on the phone and saying, we need mismatch repair deficiency status on random tumor that you'd never thought of having mismatch repair deficiency ever before. So it became clear that having a more comprehensive mechanism to deliver mismatch repair status rather than running MMR IHC on every time somebody would call you or doing MSI PCR, just to build it into our sequencing platform would make life a lot easier for all of us, which is what we chose to do. I'm not going to talk about that here. I'm actually going to talk about it with the residents at 9:15 to show you exactly what we're doing with this. But that's why we rolled this out in July of 2017. And at the same time, we thought we would just throw TNB in there for good measure because people were interested in it, correlate it with mismatch repair deficiency. And there was data that had also come out in 2015 from lung cancer, clinical trial data demonstrating that high tumor mutational burden also correlated with better response to PD-1, again, pembrolizumab therapies in patients with non-small cell lung cancer. So you can see the survival curves here. High mutation burden patients have a significantly better progression-free survival than those who have low tumor mutation burden when they're getting anti-PD-1 therapies. So it looks like it's potentially, again, another biomarker kind of like MMR that may cross over different tumor types. Of course, this begs the question of how we actually define high tumor mutational burden. Those original studies in the pembrolizumab cohorts that were published by Naya Rizvi in 2015 utilized whole exome sequencing. And of course, that's not the most practical approach in clinical practice to define a high TNB patient. So a lot of effort was made to figure out how we could kind of dial that down to targeted panels, and in clinical trials looking at another PD-1 inhibitor, the nivolumab PD-1 inhibitor in the Checkmate trial, they came upon this cut point of about 9 to 10 mutations per megabase using a targeted commercial panel, about 350 genes or so. So that's kind of, if people have been sort of following this, they'll sort of recognize this 10 mutations per megabase cut point is kind of what people get all excited about. And what we find with our OncoPanel, and this will become relevant later as you'll see, what we find with our OncoPanel results is that we'll sit down in a tumor board with colleagues from name your favorite disease center, and they'll see that we have a mutational burden of, say, 10.5 on one of their patients, and they'll say, oh, this would be a great person for immunotherapy, and you're like, this is, I doubt it, but that was sort of what was demonstrated using a different assay in a certain tumor type in one particular clinical trial, but I'm really not sure what the right cut point is for your particular tumor type. We're getting some more insight into that, but anyway, this has been kind of an interesting problem that we've faced. So, of course, the original it's sort of a signal, certainly, that tumor mutational burden predicts outcome for pembrolizumab therapy patients with non-small cell lung cancer. And then also trials that were built around looking at TNB prospectively as a biomarker for combination PD-1 and CTLA-4 inhibitor therapy, and that was this Checkmate 227 trial. This was published last year to great fanfare, and we had progression-free survival data showing that patients who have a high TNB, again defined with this 10 mutations per megabase cut point, having superior outcomes relative to those who have low TNB. And this was really irrespective of PD-L1 expression or histology. So there was a lot of excitement about utilizing TNB to select patients to get what's ipilimumab, nivolumab therapy, because there was this good progression-free survival data. However, a couple months later, the overall survival data began to mature for this cohort, and it did not show necessarily a benefit of TNB as a biomarker in predicting response. So I think this is relevant because the progression-free survival data comes out in a big, sort of well-controlled New England Journal paper, and triggers a lot of activity around developing TNB as a clinical biomarker that we have to think about actually incorporating into our laboratory. So there's places that have developed standalone TNB assays in their laboratories. There's all sorts of efforts to standardize tumor mutational burden across laboratories. And then the overall survival data comes out on this trial, and everybody's, the winds kind of came out of a lot of folks' sails. And I think it's kind of not clear where we will go with TNB as a biomarker, but there's still interest in it, but we're much more measured or tempered enthusiasm at this point. So the question then, you sort of have to do the postmortem on TNB as a biomarker and ask, well, why is it not looking very effective, at least in the overall survival setting? One of the potential criticisms could be is that the cut point that's chosen, this 10 mutations per megabase cut point, maybe it's just too low, and maybe that's just not a high enough kind of signal to really select patients who are going to clearly benefit in the long term from these drugs. So this is an interesting analysis that was actually run using the Memorial Sloan Kettering IMPACT data. They have a panel that's about 450 genes or so. It's a paired tumor normal panel, which means that I think they have a little bit more of a stringent set of criteria for actually calling high TNB. And what you can see from this interesting curve, and this is actually taking every cancer type from every patient who's gotten an immune checkpoint inhibitor, ICI therapy, and you see this sort of flexion point where it looks like when you hit a TNB cut point of about 20, you start to see kind of a flattening of that curve, suggesting that there's probably a benefit to, or an increasing benefit or an increasing a correlation between the TNB and response rates up to about the 20 mutation cut point, and then again it kind of flattens out. So it makes you wonder if we should sort of be placing that cut point a little bit higher than that originally proposed 10 from that original nivolumab trial. And then another very important observation from this group at Memorial, and to the point of like having a conversation with a clinician in a disease center outside of lung cancer about whether a TNB of 10 is meaningful, you can see where the top 20% of TNB across different tumor types actually land. So colon cancer, the top 20% of tumors is actually about 50 mutations per megabase. So that's a very different sort of cut point than, say, non-small cell, which is about 14, which again is also higher than the 10 that was originally proposed. Head and neck actually is one that seems like it's got this cut point of about 10. So you can see that TNB looks like it could be a fairly potent biomarker for a certain subset of tumors, but with a very different threshold for each one of those different tumor types. So then there's the question of how much does your TNB look like my TNB, look like some other person's TNB? And so there's a lot of efforts to begin to standardize this. Again, I think some of these efforts are a bit tempered by the fact that we know this is maybe not as potent of a biomarker as we thought it would be initially. But one of the things that we know clearly and reproducibly is that panel sequencing tends to overestimate tumor mutation burden as compared to that kind of gold standard whole exome sequencing, TNB. And there's a lot of reasons that this could happen. And this is just one particular comparison between the Memorial targeted panel assay and an exome, and you can see how the TNB on their IMPACT panel is consistently higher than that on the exome. So the issues here are that usually when we build a panel we are selectively identifying cancer genes that are highly mutated in cancer to put onto that panel. So there's some degree of selection bias that goes into building it. We have higher depth of sequencing, so we may be actually capturing more mutations that we couldn't see with whole exome sequencing. We do a lot of things to play with the technology to optimize our coverage. So areas of the genome that might not get covered very well in whole exome sequencing at all are getting picked up in our targeted panel. We've got different calling algorithms. And then for labs that are running tumor-only testing, there's this huge issue, as I've already alluded to, of the germline contamination from the patient's sort of private polymorphisms that we don't filter out, as well as issues of detecting clonal hematopoiesis variants, which we know is an issue particularly in older populations. And then, of course, the other question is, well, how much coverage do I actually need in my panel to generate a usable TMB, a reproducible TMB? And here's another kind of, I wouldn't say a victim, but another sort of product of the enthusiasm around tumor mutational burden. There was an original commercial panel that was developed that was a very reasonable 170 mutations that look like, or 170 genes that look like it could fairly reliably detect TMB. And then the excitement around TMB and the progression-free survival data came out, and they decided they needed a bit more of a rigorous assay for detecting TMB. And then they launched a 500 gene panel, which shows much more tighter associations with whole exome sequencing. And now this is the panel that one particular company is very interested in pushing to the broader community. And it's sort of a question of, well, do we really need 500 genes, or is 170 genes perfectly fine now that we know that maybe TMB is not as robust as we initially thought? But it is what it is. Just talking about the standardization efforts, there's one major standardization effort that you may be aware of from led by the Friends of Cancer Research and another group in Germany, the name of which I will not attempt to speak. But essentially, the idea here is to identify sources of variability between labs, both commercial and academic, to figure out if there's a way to generate a universal reference standard based on whole exome sequencing that can be applied across laboratories so they can generate a similar TMB irrespective of their panel, and then ultimately to figure out if we can look at large numbers of patients who have received therapy and look at whether we can identify a clinically meaningful tumor mutational burden cut point for particular tumor types. So this one is essentially, I think, right now in phase 2. Of their efforts, and I think we can look forward to a paper from the first part of this effort coming out relatively soon. In the meantime, colleagues of mine at the Dana-Farber have actually been taking the data that we've generated on OncoPanel, and we've looked at it across a variety, in comparison to a variety of different panels: TCGA data, which is whole exome sequencing data, the Memorial Impact data, as well as Foundation Medicine. Which I just not a disclosure, but just to give you a sense, the Foundation Medicine panel is actually predicated on the OncoPanel panel. So we developed OncoPanel 10 years ago or so, and actually members of our organization commercialized it to form Foundation Medicine. So it's, and then of course we've been competing with them ever since. So go figure. Anyway, so there's a lot of similarities, at least sort of structurally, to our OncoPanel and Foundation Medicine. They're both tumor-only panel sequencing, hybrid capture panel sequencing assays. So one of the things that was very interesting from their particular analysis of our data is that a TMB of 10 at Foundation Medicine, which is the one that was also used for the NEVO trials initially, is very similar to that of IMPACT. It's about equivalent to a TMB of 10 by the MSK-IMPACT panel, but it's about 15 for our panel. And this is all the germline contribution that's coming from our panel, and we have a somewhat less aggressive germline filtering philosophy for our panel than they do at Foundation Medicine. So as a result, we see a higher overall TMB, as I point out here. However, if you do a normalization transformation of this data, and a z-score standardization, and this is way too much statistics for me to actually get into any more detail, but Natalie shows some very compelling graphics showing that you can get to a very close fit between these panels by doing a couple of standardization steps. And ultimately, if you look at outcomes of patients who are getting immunotherapy, a high TMB, really irrespective of the panel, will predict response in a general trend with response to these therapies. But even at optimal cut points across the panels, the sensitivity and specificity of a high TMB is only about 60%. So it's not much better. Maybe you can consider it to be about equivalent to PD-L1 as a biomarker for immunotherapy, but it's not going to get us really, I think, above and beyond, as an independent biomarker, not going to get us above and beyond where we are with PD-L1 and selecting patients for these therapies. So, of course, we're thinking about this in the context of generating neoantigens, and one of the kind of interesting observations that's been made, and I think been reproducibly demonstrated across different laboratories, is that it's kind of more than just the mutational burden overall. It's the type of neoantigens that are being made in a particular tumor, and it's kind of the appearance of that population of neoantigens, and whether it looks like there's heterogeneity within that tumor. So obviously, if you have one potent neoantigen and it's present in every tumor cell, and the tumor and the immune system recognizes that neoantigen, then there's a chance for broader population cell killing by the immune system, as opposed to small subpopulations of the tumor cells having this neoantigen. And so that's essentially what these folks are showing. And I think what's interesting is that you see that there's a clear association between clinical benefit and having a dominant clonal population of neoantigens within your tumor cells. And it's also interesting that you can actually associate this with particular types of signatures, and that's this data here. So the gray bars here are demonstrating what the dominant mutational signature is within this population, and this is mostly smoking-related signatures. There's also an ApoBec signature here, whereas in the patients who appear not to be responding, who have more of a heterogeneous neoantigen population, there's these other signatures that are actually not particularly well defined. So whether there's a combination of multiple signatures here, whether these are, say, post-chemotherapy related changes, it's not entirely clear. But there may be a signal between the type of mutational signature you have in your sample, not just that sort of binary hypermutated or not, but what is the nature of that hypermutation, and is that contributing to the way these tumors respond? Finally, there's the antigen presentation aspect of things that we also have to keep in mind. And I'll just focus on really two things. I think one of the things we know about antigen presentation is that there's a billion different ways to potentially modify it. We see in patients who respond to immunotherapy initially and then relapse that they're acquiring mutations in things like B2M that are affecting the ability of the MHC complex to be presented at the cell surface. But it's also interesting to think that there's actually innate attributes to the patient and to the tumor in terms of the HLA status that appear to be fairly powerful predictors of response as well. And again, this ostensibly has to do with how effectively they're actually presenting and interpreting neoantigens on the cell surface. And so this slide essentially is indicating that the germline HLA diversity is actually an important factor in patient response rates to immunotherapies. This essentially is showing you that patients who have heterozygosity, high diversity of their HLA loci have better overall survival in both melanoma and non-small cell lung cancers when they get immunotherapy. And they layer this on with mutational load, and you see an even more striking survival outcome difference in these populations. And I think this is actually very interesting from the cancer standpoint. This group, McGranahan and their colleagues in the UK, looked at the HLA status in early stage lung cancers and demonstrated that if you have evidence of loss of heterozygosity of HLA in your early stage lung cancer, that's actually probably a bad thing, because this is going to facilitate immune evasion very early on in tumorigenesis. And this is actually observed, this presence of HLA loss of heterozygosity is actually observed in nearly half of early stage lung cancers, and may actually be kind of an interesting and important prognostic, independent prognostic factor in our resected early stage tumors. From the standpoint of immunotherapy outcomes in patients with advanced disease, the numbers here are small, but there's this other very interesting curve where they layer on the patient HLA heterozygosity. Are they diverse or non-diverse? Is there a loss of heterozygosity of HLA in the tumor itself, and what is the tumor mutational burden? And look at how the outcomes fare. And again, it sort of is as you might expect. The greater the diversity, the lack of a loss of heterozygosity of HLA in the tumor cells and high mutational load all predict a much better response than the converse. And then finally, we have the immune cell. So, and I think in sort of piecing all this together, to some extent, I'd like to think about the ways that we as pathologists are sort of intersecting with this field in ways that we can be developing biomarkers that we can integrate together to generate a much more useful set of information for selecting patients for therapies than we otherwise can with, say, PD-L1 alone. We're trying, in addition to offering the genomic data that we can from our OncoPanel efforts, we're now trying to bring in immunoprofiling more routinely. This is something that I mentioned earlier we just started doing in September. We actually haven't figured out yet how to deliver the reports effectively back to the clinicians on immunoprofile, but we're generating the data and sort of have it in a holding space right now until we can get the reports delivered back. But I think this data is very compelling, and it's nothing new to us in pathology. We look down the scope and see this tremendous variability in the immune milieu in tumors from one to the next all the time. We just don't do a very good job of quantifying that or communicating it at all, right? We're like, oh yeah, we know that was really highly immune infiltrated, but our oncology colleagues have no idea. They didn't get to see that slide. So having kind of quantitative way to assess this, I think, could be very powerful. Additional variable in interpreting our sort of immune therapy compatibility, if you will. So here's just two different exemplary cases of lung cancers that we did multiplex immunofluorescence on. The green is our PD-L1, pink is our AE1, AE3 keratin stain. We can see a whole lot of CD8 positive T cells in white in the background. PD-1 is overlaid with yellow, and FOXP3 Tregs as well in orange. So that's one example. And of course, that's very different than this tumor. So looks like we've got kind of a hot tumor and a cold tumor, two very different phenotypes. Again, not something that's readily, I think, delivered to the clinicians who are thinking about the treatment options with the current way that we report things out. So in terms of quantifying these things, there's way too many numbers here. The bottom line is here's our hot case, a TPS, tumor proportion score of 86, a whole boatload of CD8 and PD-1 positive cells, both within the tumor and the tumor stromal interface, as opposed to our case 2, which is really very cold, very low tumor proportion score, and you can see overall much fewer T cells overall. So again, the ability to add this quantitative information in, I think, will be very powerful if we can figure out how to do it in a way that's kind of informative. And I think to be able to benchmark, building big data sets where you can then begin to benchmark what the sort of spectrum of tumor immune infiltrates looks like, and sort of put tumors in certain bins for the clinicians could be very helpful. And then one final word is on very simply like other mutational features that we should be aware of in looking at our tumors that may actually be fairly powerful predictive indicators of response to immunotherapy. And STK11 is kind of the poster child for genomic co-mutations that appear to actually impact response to immunotherapy via some mechanism of actually triggering immune exclusion around the tumor cells. So this is one particular study that was published last year that essentially showed, doesn't matter how high your TMB is, if your tumor cell has an STK11 mutation in it, and that typically leads to loss of function of the LKB1 protein, these patients will do much worse following immunotherapy. And that was true across multiple cohorts that were tested. And that was, typically these were identified in KRAS mutated tumors, which is why there's an allusion to KRAS with LKB1 mutations, KRAS with P53 doing much better, KRAS alone doing much better as well. So again, it appears to be independent of tumor mutational burden. KEAP1 is another mutation that's been implicated as potentially leading to worse immune therapy. So it gets complicated, right? So we sort of see we have a high TMB, and we have, say, it's EGFR wild type, which is important because we know EGFR mutated patients don't do well. But maybe it's KRAS, and then it has 4 other variants that may actually lead to immune exclusion. So then what do? Do you treat, do you not treat? Potentially the phenotype in terms of what the immune cell milieu looks like, as opposed to just relying purely on the genotype, is going to be what we really need to be focusing on. But that remains to be seen. So just to summarize this first part, in general, high mutation rates look like they correlate with response to immunotherapy, but it doesn't look like TMB is going to outperform PD-L1 as an independent predictive biomarker. I think there's a question of whether it could be complementary in some contexts. Other genomic features, such as mutational signatures, other oncogenic mutations, are likely to influence this response to immunotherapy. We also recognize that tumors evolve mechanisms to suppress neoantigen presentation. HLA loss of heterozygosity is a prime example of that. And so we should be probably cognizant of that issue as well. And then finally, tumor immune milieu probably impacts response to immunotherapy because you need the immune cells there to actually affect cell killing. And we're beginning to at least pilot this effort to quantitate this immune milieu and hopefully ultimately incorporate this into routine practice for our clinicians. All right, so we'll now move on to talking about mutational signatures, more from a sort of surgical pathology diagnostic standpoint. Think about ways that we can use this to inform tissue of origin and diagnosis. So it's a, kind of looking at the individual rocks in a formation versus sort of taking the 20,000-foot view and seeing what they're actually building in a much broader sense. And so what are mutational signatures? So just to kind of back this up to what's happening at the DNA level, the idea here is that particular mutagens, whether they be exogenous mutagens, whether there be endogenous DNA repair defects, lead to very stereotypical changes in the DNA. So, for instance, in quote-unquote signature 1, you'll see a large number of C to T mutations. And you see that this sort of histogram is built up that is relating to what is the context, what is the mutation, what is the sequencing context in which that C to T mutation is happening. So what's located at the 5' side of that particular substitution, what's located at the 3' side of that. And then you can map all of that out in images such as this and begin to identify certain patterns emerging and put a signature label on them. And of course what we recognize is that each one of these signatures corresponds with very well recognized mechanisms of DNA mutagenesis, again, whether they be exogenous or endogenous. And so recognizing that these patterns are present in the DNA, and a lot of this data, of course, was built on whole exome sequencing, and that's what the data from the Alexandrov original sort of signature study was showing, but we know we can actually see this in targeted panels as well. And so we had a really very brilliant colleague, Frank, who unfortunately we lost to a car accident tragically last summer. But he was really very instrumental in building out these mutational signatures for our targeted sequencing data. And you don't need to spend a lot of time looking at this. Essentially, looking at the data from the Alexandrov study in particular, identified certain patterns of mutations, substitutions in particular sequencing context, and then Frank essentially built out rules that were predictive of the particular signature that these substitutions represented. The question then was, I think one of the challenges that we face is that the whole exome sequence, again, is more of the gold standard. You use different statistical methods to identify signatures within a whole exome that are not really applicable for the targeted panel. So we had to think of ways that we could actually validate routine use of mutational signature calling from our panel. And there's not really a precedent for this. So there was kind of a lot of infighting within the laboratory about whether this was even legitimate. There were no orthogonal assays to kind of validate this type of effort. MMR signature was easy, right? Because you can just pull your MMR IHC or your MSI testing off the shelf and cross-compare with sequencing. That was a very easy thing to do. These other things, there really is no orthogonal assay. There's no assay you can pull off the shelf that says, oh, there's a tobacco signature here. This is just sort of de novo observations from the sequencing data itself. So we had a bunch of different ways that we thought about looking at validation of these assays, including bioinformatic approaches using alternative statistical models rather than this kind of probabilistic model that Frank built, looking at other sort of less biased statistical models, something called NMF, which is what was used in that original Alexandrov paper. So we worked with somebody named Josh Campbell at the Broad Institute who helped us do this. It doesn't work very well in our data set in predicting signatures, so we kind of gave up on this. And ultimately, we just used our more probabilistic model, and we started comparing to external databases, which is something Frank did for us, as well as beginning to just compare to internal clinical data. Does it make sense? If we identify a tobacco signature, was the patient a smoker, or were they a never smoker, and then we have a problem. Part of thinking about the kind of internal clinical validation was just understanding the tumor types where we might expect to see certain mutational signatures. And this is, again, a very busy image, but essentially it's showing you that certain signatures can be expected to be seen in certain types of tumors. So the way we approached the clinical validation was to say, all right, let's focus on, we have 800 cases altogether in our overall data set that we want to call signatures on. Let's focus on subsets within that data set of tumors that are, say, lung cancer. Did we find smoking signature? Did we not? Were they smokers? Were they not? Et cetera. So we use this type of data to kind of inform the way we did our clinical validation. So essentially what we did is we took every case that met criteria for running the signature. We determined that we needed at least 16 single nucleotide variants to run it. So we had about 800 cases from the third version of our panel that we could use to do this analysis. And then we did a deep dive in the chart for all of these cases relevant to the particular tumor types that they were, and looked for smoking history to compare with our tobacco signature. We looked at MMR status. Again, this was somewhat of a separate validation effort that we ran. We looked at whether there were tumors derived from cutaneous sites to suggest whether or not they could have UV signatures, histories of temozolomide therapy, HPV status, as well as the presence of pole hotspot mutation. So this actually took a long time, and to be honest, we're actually not completely done with this effort still. But this is what the data actually looks like. So we had tobacco signature detected in about 16% of our 800 cases that we ran the signature on. So you can see that on average, this was associated with a tumor mutation burden of about 26. I would say on average for lung cancers, the TNB is around 7 or 8. So these are fairly hypermutated cases, and you can kind of pick them out almost immediately when the data will come over to you. You're like, there's a lot of variants on this list, and these typically have G to T transversion mutations that you can pick out fairly quickly. So even without running an algorithm, you often can say, I think we're going to find a tobacco signature in this particular case. And so you can see how the performance overall looks relative to whether or not a patient actually had a history of tobacco smoking. Specificity is very good, about 98%. Sensitivity is much lower. We kind of designed it this way, like we'd rather make a call of a tobacco signature and be right and miss some patients than be putting tobacco signatures in the charts of patients who never smoked. So the other thing you can see is that the vast majority of these tumors with a tobacco signature are of lung origin. The next largest piece of the pie are cancer not otherwise specified, and I think this is actually very important because this is our carcinoma of unknown primary cohort of patients. So here's, I think, allowing us to leverage the smoking signature to begin to probably push these into likely lung primary origin, potentially another site where smoking could have been a factor, but in all likelihood, these probably represented lung primaries. You can see a smaller percentage of head and neck tumors, a few urothelial tract. So again, all of these things kind of make sense. We know that smoking is associated with evolution of head and neck cancers. We know that there's some association with bladder cancers as well. It's interesting because we have a lot more bladder cancers than this, so detection of the tobacco signature is actually fairly uncommon overall in our bladder cancers, and it may be that there's a somewhat different mechanism at play in these, or they may have multiple overlapping signatures, such as apobec signatures, that may actually be competing with our sort of caller's ability to find the independent smoking signature. And then there's a couple of weird things, right? So we've got a colon cancer, which I'm not sure when my arrow will come up with that, but this colon cancer, two colon cancers, one of which we think is probably a true false positive tobacco signature. The other one is actually a patient who has a MUT-YH germline mutation. If you actually look at the literature for patients who have colon cancers arising in that genomic milieu, they evolve hypermutation phenotypes that closely resemble smoking type of signature. So it's kind of an established correlation. It's a very unusual scenario, but it happens, and so we found one here. It sort of points to the fact that you do kind of need a sentient being to look at this data, because it doesn't make a lot of sense to have a smoking signature in a colon cancer, but if you can kind of put it in the right genomic context, it kind of does, but you just have to make sure that you interpret that properly. You can see we have one breast cancer case, as well as something called a mixed ovarian carcinoma. Sorry, I have my animations all out of order, but a couple of interesting things here. I'm not sure what this one is either, so this may be another false positive. So it looks like we probably have maybe three kind of true kind of biologic false positives here. Interestingly, we have one that was called mesothelioma, but when you dig into the path report, you see that the differential was actually sarcomatoid carcinoma of the lung. So hard to say, might actually have been sarcomatoid carcinoma of the lung. We typically don't see smoking signatures in mesothelioma, though I'm not quite sure why not. And then there was this thing that was called small cell carcinoma of the ovary, which was probably actually metastatic small cell carcinoma from the lung. So here's another opportunity where seeing the signature might actually help inform that. The UV signature is something that Emil worked on when he was with us. And this one I think is really powerful from the standpoint of interpreting squamous cell cancers of the lung and whether or not they're actually primary metastatic from another site. So you can see with our UV signature, we had about 60 total cases out of the 800 that had this called. Even higher tumor mutation burden, 50. Remember, it was 26 for smoking, so really triggers a very high mutational load. You can see that the specificity relative to whether or not the patient had a tumor of cutaneous origin or not was very high. The sensitivity, again, is lower, but a little bit higher than for smoking signature detection. And you can see, again, that it makes sense clinically with the type of tumors we're seeing. So this big orange part of the pie is melanoma, followed by Merkel cell carcinoma and cutaneous squamous cell cancers. So all of that makes total sense. We have a couple of things that are a little funny. So we had one lung adenocarcinoma, which you can see there, and that actually was what it was originally called when it was sequenced, and then there was a follow-up biopsy in which they said, oops, that was actually melanoma. So I'm not quite sure how that happened, but it did. Here's another patient who had lung squamous cell cancer who was a never smoker, and actually they clinically suspected metastases, so that's probably what this is. It's a met from a cutaneous origin. We had a nerve sheath tumor. The diagnosis, frankly, was kind of unclear. Was this actually really a sort of a dermal sarcoma or a metastatic melanoma or something like that? It's unclear. Oligodendroglioma. This is a true-false positive, but this patient actually had temozolomide therapy, so we're seeing sort of crosstalk between two different detected mutational signatures, and this is another potential recognized pitfall. And then finally, this one, sarcoma NOS, was actually arising at a dermal site, so it's a question of whether this is actually just a kind of a UV-triggered process. So I think pretty useful. We actually rely on this quite a lot now to help with our clarifying some diagnostic challenges. As I mentioned, we wanted to compare the performance of our caller with that from of another institution. So we looked at publicly available data from the MSK-IMPACT panel, and we applied our caller to their data. And you can see that we had a pretty good agreement with the MSK data. One thing I would point out is that the sensitivity of our caller was actually better than the Memorial caller for detecting tobacco signatures. They actually document the patient's tobacco status in their cBioportal instance, so you can pull out that data. And we actually did a better job of finding those patients than their caller did. They used that NMF caller that I mentioned earlier. It actually doesn't look very good at calling tobacco, whereas our probabilistic one does. So we felt like that made it a fairly strong argument for continuing to use this. And then this is a summation of kind of the clinical validation. I would point out that things like ApoBec and just the ApoBec were particularly challenging to validate against, because there's really nothing in the clinical chart that says this patient should have an ApoBec signature. So we know it's associated with viral infections, so you can look at things like HPV. We only had about 15 or 16 patients that had documented HPV infection in their tumor, and so it just didn't give us very robust statistics to actually come up with the clinical performance characteristics. So this one is sort of, we know that we see it in things like breast cancer, bladder cancer, a variety of other tumor types. You can see it in lung cancer. And so when we usually see this signature, it's typically in a context that we expect to see it, so we feel okay about it, but it really is not a very clinically vigorously validated biomarker. So finally, when we actually look at this data, this is what our calling page looks like. So we'll have an automated NMR call that's made by the system. It's predicated on the number of small insertion deletions that we see in short repeat regions of the genome. So we have a certain threshold that we need to surpass in order to call it, and if it's not there, then we just call it proficient. And then we have our different signatures that we like to call, and we actually look at the distribution of the SNVs so we can see if it fits the expected pattern. And you can see that this looks like a UV signature, and that's what we would call. So just to sort of give you a sense of how this could potentially affect the way we think about sort of classes of tumors. This is an analysis we did of all of the lung squamous cell cancers that we sequenced over about a 3-year period. And we didn't actually run our signature analyses at this time. We went back and ran this retrospectively. And I think what's very interesting here is that the vast majority of patients are smokers. The vast majority then don't have any signature detected. Part of that is based on the fact that these were smaller panels, didn't generate enough variance for us to actually call a mutational signature at the time. We do have a few. We have 4 smokers with a tobacco signature that are detected. We have 1 smoker with a UV signature. So it looks like even if you're a smoker, you may be at risk of developing cutaneous metastases to the lung. That's probably what this is in this particular case. But I think even more striking is we have 17 never smokers with squamous cell cancer in this cohort, and 5 of them have a UV signature. So 30% of the time, if you, at least in this cohort, if you have a patient who's a never smoker with a squamous cell cancer, it's a metastasis from somewhere else. So I think we kind of know that in pathology, but sometimes we don't have all the information that we need. But I think putting it all together for the clinician before they start thinking about starting a, say, a lung-specific regimen, be thinking about the possibility of ruling out a metastasis from another site. So just bringing this kind of full circle in terms of how we actually report this type of thing out and how this gets communicated to the clinicians. Here's a particular situation where we had a young woman who was a former smoker who presented with extensive disease in the neck and the breasts. And so she had actually initially palpated a breast mass. The assumption clinically was that she had widely metastatic breast cancer at the time of her presentation. So they did a biopsy from the breast tissue. You can see the tumor here. It was ER-PR, HER2 negative. It was a presumed diagnosis of triple negative breast cancer made in this particular case. She got CT staging and had tumor everywhere. She had a re-review of the pathology, I think based in part on the fact that she had quite a bit of abdominal retroperitoneal disease. The re-review of the pathology actually showed that there was some CDX2 positivity and it was GATA3 negative. And TTF1 negative. So it was revised to likely being a GI primary. So she went on a GI-specific therapy, didn't show very promising response. And when she progressed, she was referred to our oncology service at the Dana-Farber, and they actually ordered the sequencing that I'll show here. And so the sequencing here actually showed a TMB of about 27. This is how we report our TMB out. We give the raw number, and then we benchmark it against other tumor types in that particular class. This was called a CUP, or a cancer of unknown primary. And this was high even amongst all of the carcinoma of unknown primaries, MMR proficient. But then we have a mutational signature that looks like tobacco. And we also have a variety of alterations here that, for those of you who look at lung cancer genomics very often, look very classic for lung cancer. So we actually signed this report out and said, tobacco signature, we recognize that this was initially considered to be a GI primary, but clinically should recommend correlation and suggest a possibility this could actually be arising from a lung primary site. This is the information that we provide in our interpretation. And so what's interesting in this particular case is that we actually have an effort with our GI docs to essentially re-annotate a lot of the information that we generate on OncoPanel. So we essentially create a synoptic of our OncoPanel report that offers a lot of clinical therapy recommendations. So we sit with a core group of GI oncologists, their clinical research coordinators, and several pathologists, and kind of go through the OncoPanel reports and say, this is what we think your top, say, 3 treatment suggestions should be for this particular patient. So in this particular case, this was recognized that this was probably a thoracic origin rather than a GI origin, and a recommendation was made to transfer the patient over to thoracic oncology. And I think the important thing here is that actual acting on that recommendation didn't happen until this report came out. So we had actually issued our OncoPanel report with a kind of a suggestion buried in our comment that this was probably a lung primary 2 weeks prior, and nothing had happened. But you kind of you kind of rally the forces, and you have a very clear communication about that sort of change in diagnosis, and that makes all the difference in terms of getting the patient referred to the right place. So to summarize this second part, mutational signatures are derived from patterns of nucleotide substitution in their sequence context. They're tumor and tissue type specific, related to the actual type of DNA damage that's occurring, and that we've shown we can really roll these into our targeted panel sequencing interpretation and into our routine clinical testing. And I think this is a very impactful approach to analyzing the sequencing data. I have a whole bunch of colleagues that have done most of this work that I have to thank, and I'll leave you with these few take-home thoughts and take any questions you might have.
Unfortunately, we don't have time for too many questions, maybe a couple.
Yeah.
Yes, John.
Fascinating talk, thank you. In one of your earlier slides, you talked about looking at cells infiltrating around tumors.
Yeah.
And one of the cells you were looking at was FOXP3. Could you comment on how that's used by pathologists and clinicians?
Well, I would say it's probably not being used right now. I think there's some, I think there's some suggestion that we see increased numbers of those in our quote-unquote hot tumors.
Yeah.
But to some extent, it's a bit of a pet project in terms of identifying which markers we put on this 5-marker panel, because we have a set number. One of the immunologists was particularly interested in looking at FOXP3 in this setting, which is why it ended up on our panel. I think if you talk to folks at Yale, they would argue that we should have granzyme B as a marker on here rather than that. So, but again, we're limited. With this type of technology, we're limited to say 5 or 6 markers overall, and so we're to some extent it gets a little bit arbitrary in terms of what we choose to put on. Question over here.
Yes, please.
Thank you for a great talk. From a clinical practice perspective, what is your turnaround time from the time the tumor gets to you to the time you generate the report?
Yeah. So well, it depends when you start the timer, of course. So there's all sorts of ways we can kind of trick the system into shortening our turnaround time, depending on when you start the timer. But so we require, for the laboratory, we require that we have the request for testing and the tumor tissue in hand before we kind of initiate the timer. And then when it's a clinical case, our median turnaround time is 11 days. When it's one of our research, kind of more cohort profile cases, it's between 2 to 3 weeks. The immunoprofiling assay is taking us around 3 to 4 weeks to turn around right now. Of course, as all of you know, just getting the tissue into the laboratory is no small feat. So if you start looking at it from the time that the order was placed by the clinician until we actually get the report out, it can be a lot longer.
Yes.
Have you looked at, are you guys looking at gene expression signatures at all in correlation with the mutation signatures?
Yeah.
To see if there's any...
We're not. It's a bit out of our wheelhouse right now. I mean, I think there's certainly a lot of interest in at least, say, looking at interferon gamma expression signatures and that kind of thing.
Sure.
But we've stayed away from that thus far. Yeah. Okay.
One
Sounds
more
good.
question, please.
Great talk.
Thanks.
I want to comment on the tobacco signature. Chart guides may only tell you, or not, that someone is a smoker.
Yeah.
It may not reveal living with someone for 40 years.
Absolutely. Yeah.
Or other exposures that
Yeah.
may be quite significant.
Yeah. No, I totally agree. There's certainly limitations. Certainly limitations to this, and I think it would actually be very interesting. The secondhand smoke is challenging, right? Because as you point out, it's not necessarily quantified, and it's sort of like marijuana exposure, same kind of thing. These things are not quantified in a way that we can actually correlate effectively. I'm kind of hoping that because we've legalized marijuana, I don't know what you guys have done, we've legalized marijuana in Massachusetts, that maybe people will actually be open about what their usage is and we can actually quantify it in the charts better and actually begin to draw more robust correlations. But it's a very important comment, and we recognize that we're going to see some degree of limited sensitivity and specificity in correlation with clinical results because there's these intrinsic limitations to the way this type of thing gets documented. I don't know in the end if you're going to see the same tobacco signature for a secondhand smoker as you will for a primary smoker, and that's not something we've been able to sort of delve into just yet. So,
Thank you very much.
thank you.